Good afternoon. Welcome to this podcast called OncoTalks by Suchitra Cancer Care. Today we are going to talk about a new treatment strategy which is called precision oncology. And to share about this approach, we have an expert, Dr. Sewanti Limaye, who is currently based in Mumbai in the Reliance Hospital. Welcome, Dr. Limaye. At what point of time did you develop interest in cancer care specifically?
So that was in the first year of my internship. I had no awareness of cancer medicine, cancer care. I was struggling with a personal calamity, and I was really carrying a lot of baggage. And in those times, I made it into residency. And through my residency, as my year of internship was coming to a close, I went for a regular rotation to Sloan Kettering Cancer Center, which we used to rotate through. And when I went there and I met with the cancer patients at large, I was completely transfixed. I've never looked back since then. I was changed for life. Because I realized that I was carrying a lot of baggage with me when people who were really abreast with death and dying had such heroism within, and they were defying death, and they were so brave. And so that was a very sort of a moral learning which transformed me. And
was there any particular patient or any particular interaction?
Oh my God, there was I was overwhelmed in that 1 month, and I was so overwhelmed and so enamored that I actually literally asked for student housing at Sloan Kettering. I moved across their building, and for 6 months I did not leave. I bartered all the electives with everyone because nobody wanted to do oncology electives, and people had to come rotate through Sloan. So I bartered all of that. It is only when I was exhausted with my own electives that I went back to my parent institution. So
in your talk you were mentioning about Dr. Bosner, I guess.
So multiple people, of course, influenced. At Sloan, during my internship, the person who really stood out was Professor George Bosel. Professor George Bosel was the physician-in-chief, one of the senior guys. And his theory was tissue is of critical importance. And it's not cancer until proven otherwise. If it's cancer, it's curable until proven otherwise. If it's not curable, it's still treatable until proven otherwise. And if you can't treat the cancer, you can still always treat the patient in life and in death. So very, very
human-centric approach would
human-centric and very pivotal message to the young intern and resident crowd, where one learned that cancer was not just about getting responses. Cancer was about anchoring a journey from life, a lot of times unto death.
Like as a caregiver, I've been in that position, and I think I can relate with that a lot in terms of, even if, death is staring at your face, there is still life.
There is still life. You still need to do respectful rendering of your services as a caregiver for your loved one. And their suffering, their pain is every bit yours. And so that message, very young in my life, was very pivotal. But what was really transformative is many patients who I saw, because we used to do, as interns rotating on the service, we would do a lot of inpatient coverage. And in the US, 90% of oncology was being practiced as an outpatient. So inpatients were the patients who had advanced disease, who had really poor quality of life, who required multiple admissions and who were probably near end of life. But you saw such resilience in them. It was incredible. And then the study that I spoke of, where these were metastatic breast cancer patients, and Jose Baselga was right around that time discovering trastuzumab, and there was a new drug on the horizon, where you saw transformative change happening just because you recognized a pathway. And that was very, very pivotal again, where while I was doing the data collection, very basic data collection on these patients, the realization that if you found the silver lining, maybe you'll be able to bring about a different result.
Great, great. So how many years were you there in the US, and then why did you make such a, big move back to India? Not many people are able to do that.
So mainly for family. My parents-in-laws were not well. I have lost them both now. And I want to say that I understand the caregiver's journey. It's been 1 year that I lost my mother to advanced lung cancer. So I'm very much in your place. And today, as I come here, I brought my father here with me because I just couldn't leave him even for a few hours in Patna. And I said, you come with me because I'm getting a chance to come back home. So pivotal reason to come back was family. But it's been quite an eye-opener. The practice patterns are quite different. A lot of my growing up years I had spent in the US, especially the work culture is very different. The volume is very different. So it's different.
With our population, one can
US patients multiplied to 100 is the number that we see here. And so systems are not as strong, and in that it can certainly be overwhelming, and I think all of us are overwhelmed, right?
So in your talk, you shared about precision oncology. That's something honestly very new for, even oncology is such a complex field. But if in layman terms you could share a bit what.
So I actually said it. It's the silver lining. So it's silver lining in cancer care. So you have today 3/4 of all cancer patients getting diagnosed in advanced stage, where you cannot promise cure, where the time is limited. And if in the journey you're able to figure out very early if there is a pathway that could give a different meaning to this patient, why wouldn't you do that? So I think this is not a cliche. This is the way to practice oncology. Instead of wasting time, energy, money, resources, and lives on, regular bucket treatment, one would want to immediately understand if I have less time left to get from here to Patna airport, am I not going to want to know the best path? The shortest path, the easiest path, the fastest path.
That's Vande Bharat, by the way.
Yeah.
These days, it takes 1 hour to reach Patna.
Amazing. So yes, I was trying to look for my Vande Bharat. So it's the silver lining that one is seeking, and only I am not seeking that. I think every patient is seeking the silver lining. Anyone who wishes to live is seeking the silver lining. We have been caregivers. Think about it. If we had a silver lining, wouldn't we just jump at it?
Of course.
So that's the thing.
So how is precision oncology then different from, common cancer treatment types like chemotherapy, radiation, or surgery?
Yeah, very good question, and actually very simple answer. So precision is an orientation. जैसे हम बोलते हैं, yoga is a way of living. Yoga is not separated from normal living. You cannot separate someone who practices yoga by saying, oh, he's a yoga practitioner, he has to sit in another room. Similarly, a medical oncologist who practices precision oncology is just practicing a nuanced way of oncology. It's not practicing something very different. I do practice something more than that. I do practice multi-pathway or other kinds of more evolved kind of precision oncology. But precision oncology at large is about recognizing these pathways that cancer is made of and harnessing those pathways to give better outcomes. And it has now been proven over the last decade, even more than that, decade and a half, that if you were to identify a biomarker and strategize treatment based on that biomarker, that the results could be different. And this has played out pathway after pathway after pathway. So to not recognize that biomarker and just give generic treatment to all lung cancer patients or to all breast cancer patients, to me is not smart anymore.
So what would it entail, say, for the breast cancer patient and for a lung cancer patient?
So mostly, if a patient comes to me in stage 4, that just means that the time is limited. That just means that you have to look for the fastest path. You have to get from here to catch the Vande Bharat, and you can't miss it. Because if you miss it, you're not going to get to the airport and you'll miss your flight of life. So we need to quickly figure out what are the pathways. So if let's say a breast cancer patient comes to me and I'm starting them on standard treatment and the patient is stage 4, I would like to know what are the chances that this patient will have a very prolonged benefit from the target hormone therapy that I'm giving, or what are the chances that this patient may fail that treatment quickly. Or it could also mean which targeted therapy to give, this one or that one, based on the findings. And if the findings are of aggressive disease, I may give a little different targeted therapy than the other one. And this is a journey we go through every single day. I showed a case today where in a head and neck patient, we found a pathway that is usually seen on breast cancer, in breast cancer. So point here is, if we don't look, we will not find.
So what do you mean by pathway? Like
we do genomic analysis.
Okay.
I do some more stuff, transcriptomic analysis, chemosensitivity, what we call functional analysis now, by testing the cells in a petri dish with different drugs, so that you don't experiment on the patient, you bring back that experiment directly to treat the patient to patient's advantage.
That is interesting. So, and what do you see are the barriers to precision oncology?
It's expensive. The testing is expensive. The treatment is, many of the treatment options, you find a pathway, but you don't have a drug in the country. So I'm a big advocate for bringing novel therapies to the country in form of clinical trials. I'm really pushing at every level possible and trying to raise. So I now feel I'm an activist more than a doctor, because I push for cancer awareness, cancer screening, availability of clinical trials, decentralization of cancer care, all of that.
Yeah. So there have been some good developments in Bihar and UP in that context. Like in Banaras, we have a big Tata hospital, which is Muzaffarpur. New one has come up. It's still in a nascent stage, but but coming up well.
And here we are.
In Bodh Gaya, talking about all of this.
Exactly.
So those are definitely good developments. So we talked about the cost angle. So what, for a patient to undergo this kind of treatment, what would be the typical cost? So
costs have come down, but still they remain quite unaffordable by a large population. I would say only 1% of India is able to afford what I call designer drugs like immunotherapy, specific targeted therapy. But it was heartening today, even in this meeting, to see there are very, very novel drugs available as part of clinical trials. Drugs that would cost millions if we were to take it off of a study. If you were to purchase it and take it, and many of these drugs would not even be ready for purchase. You cannot purchase them because they are in trials right now. But you know from stories, from hearing patient histories, that these drugs are working. So if we participated, India as a country participated in clinical trials, it would really do the demand and supply a justice.
So are we doing enough of clinical trials,
No,
or are we
not.
just confined to 2-3 major centers?
I would say a dozen centers, but we are with very low numbers in general. We have very limited trials open throughout the country for 1.5 billion of population. We have just around 400 plus clinical trials in 2023. So the numbers have really been dismal, and we as the oncology community have to step up and advocate for more clinical trials to come, because that just it equates to having drug access, novel drug access.
So for comparison, what volume of clinical trials would other countries have?
So, I was a faculty at Dana-Farber Cancer Center, and I was an early drug development person, which means first in human trials. We had 80 clinical trials running through that center.
At one hospital?
At one hospital. 80. So, you can imagine that's just one hospital catering to these, and this is just early drug development studies I'm talking about. If you just put together, alone Dana-Farber would have 3-digit clinical trials.
That's quite interesting.
Yeah. So I feel we have to go a long way, and we really need to work a lot in terms, because anything new in oncology will first be tested, right? Will be in trials. So we need to step up and participate so that we have access to these drugs sooner than we have right now. One. And two, because pharma funded trials are funded by pharma. They are for the patient free. And for the patient, it is lack of access. So it's 2 + 2 = 4. And that's where it's very critical, not just for targeted therapy, chemotherapy, immunotherapy trials, but for all novel therapeutics that are coming. And we just were hearing a talk on CAR-T, and a lot of these trials with TILs, CAR-T, cancer vaccines are available in clinical trial format, which actually are, we totally lack those trials here. And I was at a meeting in Europe just last month, and quite disappointed, very intrigued and energized by seeing, these many molecules are on the horizon, but disappointed because we have none. So a long way to go for India.
And since you are from Bihar, like pretty much grown up and, at least you're...
pretty much grown up in Bihar. Yes, of course.
So how do you see the cancer landscape in Bihar and in this region generally, like what we call the Gangetic Plains?
So one of the initial vivid memories of this is when I had come back to India 8 years ago, and I was at a meeting where actually Dr. Prashant, my friend, had taken me to a meeting at a center called VCR Park. And there I saw the first presentation on National Cancer Grid that Dr. C.S. Ramesh was making. And in that, his India map was showing where all cancers were prevalent in India. And the entire Eastern India was black, because that was the kind of density we were seeing in Eastern India of cancers. Okay.
And why is that so? I mean,
so we have, the entire Gangetic belt is considered to be very high risk for cancers. And a similar thing exists also in Punjab. there is a train that runs through Punjab where they say that's an entire belt and it's a cancer train. And similarly, when you look at the east, the northeast, we have a very high incidence and prevalence of cancer. So I think just by painting that picture, I'm able to convey the message that there is this very high need of cancer healthcare delivery systems in Eastern India, which we lack. So we lack basic care, we lack higher level of care, and we most certainly completely lack cancer healthcare delivery systems in this part of the country. And I commend the systems and the people who have come back to Eastern land and have really made a difference. For example, people who are at TMH Muzaffarpur and are helping build that. But in reality, there's really a long way to go. And so people like myself should spend more time in coming home and trying to contribute in every way possible.
And how do you see yourself doing that?
I've made several attempts actually. For the last 5 years, we have been attempting. Around 5 years ago, myself, Dr. Prashant, Dr. Kumar, we all tried to come together to set up an initiative where we said we'll do Shramdan, which means we will come here to see patients, lend our expertise. And then COVID happened. And so that came to a halt. But good and bad. I'm an optimist. Otherwise, I wouldn't be in oncology. And so the good is that during this time period, a lot of very strong young leaders have moved to this part of the land. And Amit is an example of one such leader. And I think Patna has like 12 DM oncologists and it's like thriving. So I think a lot of movement already happening in the positive direction. And the hope will be that we'll be able to really give back to India in a big way. I see that transformation happening slowly but steadily.
Great, thanks. And any last message you would like to share?
So two messages.
Yes, please.
One, look for the silver lining, never give up. And two, it's better to prevent than to treat. So my mantra is, have you screened this year?
Great.
That's my mantra.
Great, good.
Thank you. Thanks for having me.
Thank you so much for your time.